So the demands on general practice have been rising over many years. The population's getting older, older people have more chronic disease, long-term conditions. People expect more from their general practitioner. People want more convenient hours. There are new technologies that we can use to give people primary care in different ways. So all of that is putting a lot of pressure on general practice. Plus the financial climate we're working in means that they're very under considerable financial pressure. And then regulatory requirements, actually meeting Care Quality Commission standards is tough for small practices with just 3 or 4, 5 staff. So the viability of the traditional model of general practice is really quite under discussion at the moment, and that's why people are talking about new ways to organise general practice. Well, we've been looking at different models in projects that we're doing here at Nuffield. So one model is what we've called the super partnership, where local practices in the same geographic area are merging to form one large partnership. So the one we've looked at, the Vitality Partnership in Birmingham, has brought together 7 different practices and now has a list size of 50 to 60,000. And with that kind of scale in your organisation, you can start to do things very differently. Managing the regulatory requirements is much easier. You can invest in infrastructure, in IT, in new staff to improve quality. And also you can begin to do services beyond what's just traditional core general practice. You can perhaps work with local specialists to deliver integrated dermatology services or gynecology. And that creates a whole new set of opportunities for the patients registered in your practice. Then another thing is just small practices that have grown over the years to become 25, 30, 35,000 patient practices. They also have those advantages of scale and of a much more sophisticated infrastructure that can let them manage quality, regulatory requirements, HR, staff, that kind of thing. And they can create new opportunities for patients. They can invest in technologies, in internet communications, in electronic consultations, so it creates a whole new experience for patients. And then the third model that we've looked at is what we're calling networks, or what people around the country are calling networks, where GPs stay in the small practices that we know that patients like. They like the continuity of relationship with a single GP or just 2 or 3 GPs, know the receptionists. They don't want that disrupted, but they want the benefits of scale as well. So they're coming together in networked organisations. They retain their individuality, but they're finding ways to hold contracts together to provide services jointly. And that is enabling them to do new and more extensive kinds of services as well. So that's a very difficult question, and in one sense we have very limited levers. It's NHS England who hold the contract with general practice, so we can't simply vary the contract to change how general practice operates. What we can do is constantly maintain the narrative that is about the health of the population that we're commissioning for, and draw our professional peers into thinking differently about how to address that challenge. And very often that creates ways in which we can encourage GPs to work differently. For example, we are commissioning diabetes care differently. We're pulling it out of the hospital and into the community. And as part of that recommissioning diabetes care, we're looking at whether we can commission groups of GPs to work together to identify those in their clusters who have more skills in diabetic care, and to perhaps work across practice boundaries to deliver care that might previously have been done in hospital. So there are ways that we're looking at using NHS contracts to encourage GPs to come together and work differently from how they have in the past.